Welcome to another exciting episode of Unzip, Reboot, and Leave podcast. Today we have a doctor with us. He is urologist, specialized in uro-oncology. He is also a professor of surgery at Monash University. He is Dr. Shomik Sengupta. How are you today, Shomikda?
Very well, thank you, and thank you for inviting me along to this episode.
Thank you. It's my pleasure. So today, as you are a urologist, so we will talk about little bit urology, around urology, then cancer, because you are also uro-oncologist, future of surgery, and some societal aspect or mindset towards this treatment and this whole thing. Okay. So my first question to you, Dr. Sengupta, is for a general public, is there any early signs of urological problems or cancer they should not ignore at all?
Yeah. Look, that's a pretty broad question. The sorts of problems and issues that we see for our patients, probably the commonest things are difficulties and issues with urination, urine passage. And to clarify also, the majority of our patients tend to be men. We're a very male specialty. Some people think we only treat men, but we also treat women because women also have urinary problems. In men, we treat both urinary and sexual problems. In women, typically speaking, our focus is on the urinary aspects, and the sexual and reproductive side is obviously treated by gynecologists, so that's a different specialty and a different expertise. So we see both sorts, but because men have the prostate and there's a greater range of things and a more frequent occurrence of things that affect men, we tend to see more men. And the commonest things we see, as I said before, is urinary difficulties or various sorts of issues relating to urination. In most cases, that's not reflective of cancer. There's a variety of different things that can affect it. Um, we see things like stones and other sorts of issues that present not with urinary symptoms per se. They may cause pain somewhere and so on. Probably one of the most concerning symptoms, and thankfully most people don't ignore it because it is concerning looking, is to see blood in your urine. And most people would be aware that if you see blood anywhere, whether you cough up blood or you have blood in the stools or blood in the urine, it's a worrying sign. It doesn't, again, necessarily mean that it's cancer, but it's one of the things that could reflect underlying cancer, and it needs checking out. So the important thing to send as a message, I guess, to anyone listening to this is that if you have blood in your urine, don't ignore it. Don't think that it will go away, or for that matter, if it goes away, think that that's the end of the story. It does need some checking up and some testing to make sure that it isn't something serious like a cancer. So I guess in brief, that's the sort of starting point of the various sorts of things. As you can imagine, I could show you the shelves behind me. There are books that are 4 volumes in size. That is the length and breadth of urology, which our trainees need to learn, etc. So there's a wide range of things, but very commonly for lay people, those are the sorts of things to look out for.
Right, right. Okay. Any lifestyle or dietary impact you can talk about? Is there any?
Yeah, and again, this is a question that's very commonly asked by patients. And I normally answer by saying, to be honest, the whole body is connected. And what is a good, healthy diet, what is a good, healthy lifestyle, is very thankfully going to help every part of your body. And this is not my saying. A very famous doctor and a nutritionalist from the US often used to say that what is prostate healthy is also heart healthy. And in fact, in almost any situation, one of the common things that ends up being a health problem, and in fact ends up being a fatal health problem in many people, is heart problems. So in fact, whatever we can do to improve our general health and our heart condition, and just general what we call metabolic health, is very thankfully those things help with your bowel health, with your prostate health, with whatever it is that you're talking about. So that makes that answer very easy, but it doesn't often answer the specific question that patients have in their mind, which is, what can I take that will make my prostate cancer go away? Or what can I take that will prevent me from ever having a stone? And the honest answer to both of those two things is very rarely do we have something that will very specifically eliminate something. There are lots of people who on the internet will claim that you buy my product or have this particular thing and that will be the savior. And the honest truth is that all the research and the studies that have been done, typically speaking, does not support that. There are things that are better for you and might be good for, to take the example of prostate cancer. We know, for example, an Asian diet with more soy products and so on in it, a Mediterranean diet with more tomato and olives and olive oil in it are good things for reducing the risk of prostate cancer. But that's, one small facet. And again,
Mm,
the example that I give or the point that I make to my patients, tomatoes are good for you. If your diet is entirely tomatoes, that's not good for you.
mm,
And regardless of what anyone out there says, what you're best off doing is having a healthy, balanced diet. And to me, I'm a pragmatist. I think if you think about, we all know what are the bad things for us, but if you think I will never have anything bad, I will cut out alcohol, I will never have a cake, it's not a pleasant life, and you're cutting out a lot of your pleasures. So I always say to them, if you have a pleasure, if you have a guilty pleasure, it's okay. Have that. Have a steak, have a beer, but have them in limited quantities because we know that the harmful things, if they're there in limited quantities, it's manageable. It's when that becomes our general and basic diet. All we eat is junk food, all we drink is soft drinks or alcohol. That's not good. And I think those principles and those things are well known. There are very occasionally specific people, specific patients, specific conditions where we say don't have this or don't have that. But those are rare exceptions. So I think for the average person, without one of those specific things, a healthy, balanced diet, managing stress, doing regular exercise, these are principles we all know. We could all do a little better, even if we're doing some of it. On the other hand, if we beat ourselves up every time we have one of the bad things or have a treat, that's also not good for our life. So it's sort of that's my take on it. That's advice I give patients, and that's advice I'd give today.
right. As a layman, sometimes regarding this stone related problem, my grandfather and father used to call it like drink water as much as you can. And
Yes.
typically in Melbourne, because it's like winterish, like more we don't drink that much water, just
Yeah.
water. Is that
Yeah.
a problem, or it's all just again a small facet of it?
Look, again, with that, that's another conversation I have repeatedly with my patients, and especially a patient who has had stones. It is one of the pieces of advice we give that because stones form because the urine gets over concentrated, urine
Yes.
contains in it a whole lot of stuff, which can some of them can form crystals, and that leads on to forming stones. So if your urine is more concentrated and has more crystals in it or more concentration of crystals in it, it is more likely you will form stones, and vice versa. If you drink more water and make it more dilute, it will reduce your risk. So what you've heard from people know, lay people, especially in previous generations, had a good idea about these things. You drink more water, you reduce your risk of stones. But the flip side of this is, and like everything or most things in life, there is kind of a sweet spot. So, as a result of all of this, and drinking the good amount or the right amount of water is good for our health. But there is something out there that says you have to drink 8 glasses of water or 2 liters of water, and I think that this is a problem with that. That if there is one number like that that's floating around, the truth of the matter is that if you're talking about a tiny little 50 kilogram Asian lady versus a 150 kilogram big, rugby player, you can't have the same number for both of them. If you're talking about a 35-degree day where you've been playing some cricket or working in the garden, as opposed to the 12-degree Melbourne winter's day where it's raining outside and you're not being physically active, the same number can't apply to both of those. So the point I'm trying to make is there is a right amount of fluid to drink. And for us as urologists, one of the things that too much fluid can cause is that you're drinking lots, you're going to the toilet lots, and then patients come to us and say, I'm going to the toilet every half an hour, I'm waking up 5 times in the night. And then you explore it, and they're having 5 cups of coffee and 3 liters of water and drinking tea or coffee before going to bed. It's a natural consequence of that. What goes in has to come out. So if you tailor it and you tailor it according to the conditions, you tailor it according to your size, we have a very good body mechanism that tells us when we need more water. If you're thirsty, if it's time to drink. And the important thing is to drink regularly. Again, with some very specific conditions, if you have stones or if you have particular underlying predisposition to stones, we might say that you have to drink minimum 2 liters every day, things like that to that particular patient. But by and large, for the average person, listen to your body, make sure you drink to the extent that your body is telling you to drink. Keep an eye on the urine. If the urine is coming out looking watery and clear, then it's okay. If it's starting to get very dark in color, dark brown, dark yellow, that's telling you that it's getting more concentrated. And then you perhaps need to drink a little more. And by doing that, you will do a reasonable job. You drink more during the day, early part of the day, morning, afternoon. You'll see I've got my bottle of water with me. And then as you get to evening, the last 2, 3 hours before going to bed, try to make sure not too much fluid goes in. Not too much even food goes in. Some people have their dinner very late and just even solid food and dinner will contain quite a bit of fluid. And so it's good to have that last 2 or 3 hours of the day before you're going to bed with not very much going in. If you're thirsty, have sips of water. Have drier snacks if you're getting hungry before bedtime. Don't have, a big plate full of standard food. And those things just help maintain your body in the right way.
Wow. Okay. Yep. Now I'm coming to the treatment side of it. Okay. So three things like I'm explaining in one go, and then you can answer. So first is cross-border collaboration. Is anything happening in your field? And second is AI and robotics. With those help, how the surgery in your world is actually changing or will change, or yeah, please explain that.
Sure. I'll deal with them separately in sequence. So cross-border collaboration is very important in medicine generally, and certainly urology is no exception. Um, it doesn't always happen. It doesn't always happen ideally. In Australia, I guess, we are in a unique situation in being very far away from the rest of the world. And so, and we particularly now don't have a huge amount of local, certainly manufacturing and so on. We do on the medical side at least still have quite good research and development. So there is some very well performed and high achieving researchers in medicine generally, and within urology, the same thing applies. Um, but those things can't exist in a bubble. So we all work in a sphere where things are being developed in the US, in North America, in Asia, and it's important for us to know what other people are doing. Because we learn from that, and then someone might have an idea that we then take and develop further. We might have an idea that might require collaboration from other people in order to study that, to run the trial. We're a small country in Australia, so we can't do everything here. And we travel all the time to international conferences to find out about these things, to other locations, to other universities and hospitals in order to learn what other people are doing. And all the time. I mean, medical science and knowledge is changing all the time, so we are learning all the time. And even something that you feel, I know that, I know how to do that, you see something done a different way, done by a different person, and suddenly you have an aha moment and you change your point of view or the way you do things and things like that. So, to answer the first question, cross-border interactions and collaborations are very important. Um, it used to be more difficult to do, I guess, in the modern world, just like, we can talk over Zoom in this way, attending conferences virtually, having Zoom meetings, and those, the electronic media for communication has become so much easier. I remember talking to my grandfather who did research in the early part of last century, and doing anything and collaborating with his collaborators in Germany and UK was such a big deal. It was such a difficult process with sort of physical copies of things and translation of something from English to German and so on. I remember the barriers that he described. Whereas now we have Google Translate. Now we have probably a much more homogenized world where our international collaborators, even if it's not their first language, have a better grasp of being able to communicate with us in English. And we have instantaneous communication. We can email, we can meet up over Zoom and things like that. So, the short answer to your first question is yes, very much. And I think my personal view on this is whether we're talking about transborder collaboration or even, collaboration. It used to be institutions or departments were very much compartmentalized. I work at Eastern Health and we are Eastern Health. That's all we do. Now I work much more with the other hospitals around Melbourne, the other hospitals around Australia. We have national collaborative trials groups and so on. And we have much better strength and much better productivity in doing it that way by collaborating with our colleagues. So I think that is happening a lot. There are always limitations. We do still have parts of the world, the less developed countries, Africa, parts of Asia, where we don't have those collaborations as well developed, and there are natural reasons why that happens. I personally am very committed to try and improve those communications and collaborations, particularly with Asian and Indian collaborators. And I think in the future, hopefully, it will only keep on increasing and spreading its reach.
Right. Right. Okay. And the other part, which is
Yeah.
this AI
So
and
the other
robotics.
question was regarding, I guess, technologies and new developments. And the robotics and AI are two slightly different questions. So, particularly from a urological standpoint, robotics is something that we have had now for a fair period of time.
Hmm.
We do lots of surgery using a particular robot. And robots, I'm not a robotics expert, but as I understand it, robots themselves is a very broad term. So you can have robots that are essentially autonomously doing things on, the factory floor or, loading your Amazon parcels and things like that. In medicine, there are probably a few like that might undertake certain tasks. But when we come to surgical robots, very many of them are what we call slave robots. In other words, they're just an instrument. They're no different to having a scalpel or a scissors or something like that we might use. What they do is allow us a way to do the thing that we want to do surgically. And in other words, it's a surgeon that still does the operation, not the robot. So that's distinct from the robot that loads your Amazon package, where the robot loads the package with whatever information is fed into it. That information has obviously come from a human, but the human has no specific role in the actual loading of the parcel to send out. So sometimes patients hear the word robotic surgery and get a little bit concerned that we're letting loose a machine on them. The truth is that in any healthcare system, certainly when it comes to surgery, certainly when it comes to urological surgery, we use a whole stack of machines. Not all of them are robots in that sense, but we use machines all the time. So patients should rest assured that machines are being used by trained doctors. There's anesthetic machines under the anesthetic team's control. There are surgical machines that we control to do the things that we need to do. And like I said, I'm talking purely about the robot that we use to do a lot of prostate surgery, kidney surgery. There are other robots that control orthopedic surgery, the way they put in joints. There are increasing range of robots that are applied to various aspects of medical care generally, and certainly the practice of surgery. AI, on the other hand, it's certainly taken off more recently. I mean, it's been around probably for much longer than all of us have heard about it, but taken off in the general sense more recently. And certainly in medicine, it is taking off now in terms of looking at its application. And there are lots of AI applications that are already happening or certainly being tested and might be happening very soon. To give you a couple of examples, I have colleagues, I haven't yet bought into this, but may do soon, that utilize AI in order to help them with the record keeping. So whenever we see a patient, we obviously have to document things. And to date, the traditional way is that we talk to the patient, we put down whether it be typing these days or writing in the past, what we have talked about. Then that in some way gets kind of changed into a letter that then goes out to the GP or a set of instructions that goes to the patient. And there are effort and time and inefficiencies and errors in all of these steps. I might write something down that is my interpretation of what you have said as my patient, and that may not be entirely accurate. And now there are AI processes and programs where you can have a microphone, just like what we're talking through now, that will listen to the entire conversation, all of what we've talked about over 10 minutes or half an hour. It will put that into a transcript. It will interpret that into a medical note. It will develop from that a letter that can go to a GP or some other doctor, and it will generate a set of patient instructions that translates what the doctor has told the patient into a written form that can be given or emailed to the patient. So, by the end of the conversation, the computer program is doing this, and it doesn't need any of that extra time and effort to do so. And I don't know that it's been systematically looked at. I'd be willing to bet it is more accurate and reflective of what has been the underlying discussion. So that is a very simple example of AI being used, not to do any of the treatment or diagnosis or anything else like that, because those things are much harder things to put AI to. But it's just in that transcriptional communicative side of medical practice, which increasingly takes up a lot of our effort to make sure we do that right. If we have something like that, that makes that process easier and more instantaneous. Instead of having to wait a week before all that's been processed and developed, at the end of the consultation, I can get all of that ready. It's a much better process. AI is being applied and trained and tested in some of the kind of automatic pattern recognition type of things. So looking at pathology slides, looking at radiology images, things that, with the benefit of AI, will AI ever completely replace a human input into it? Probably not, because what AI and any kind of computer technology is good at doing is the automated part of it. AI can learn from that and can get better at the interpretive part, but can it ever get to be as good as or better than the human? Probably not. And I think the benefit of having the human involvement is the thing that humans are better at doing is intuition and correlating things. And especially when you're talking about having a doctor or a service provider, more generally speaking, ideally, hopefully, they have some insight and some input. So if you're my patient, I've hopefully got to know you over the years, and I will have something extra that will tell me that in addition to everything that you've told me, I will do the so-called reading between the lines and say, you sound like you're a bit depressed today. And the computer may not be as good at picking that up because they won't have that context from the human interaction. So I think when it comes to those aspects of diagnostics and so on, AI is already proving its worth and its benefit in terms of helping with the automatic parts of it. The fear in some sectors or the hope in other sectors is that it might replace or take over the work from the people. I suspect it probably never will. It certainly won't do it in the short term because it's just not going to have some of those other aspects of things. And again, not my own words. I heard someone put this in a very pithy way that will doctors get replaced by AI? And I think this applies to very many professions in addition. And the answer is no, but a doctor using AI will replace a doctor not using AI. So it may well be that this will become another tool. We use the internet, we use Zoom, we use a whole host of tools. AI is another tool, and the tool will help us to do things better. The tool will bring things that are negatives and harms. I mean, the internet brings a whole stack of negatives that we have to try and manage and control, and so will AI. But we will be able to better do all the things we do. For me, being a urologist, if we have AI to help us.
Wow, very nicely put. Very, very nicely. Now I come to the cancer side of things. Is cancer is a urban disease or any corner in the world in rural areas also can get cancer, but maybe there is not much facility to diagnose that. Maybe that's the problem.
Yeah. Look, I think the answer to your question is both yes and no. I think the truth is cancer can affect anyone, anywhere, anyone, anyhow. One of the very sad things, referring back to a previous question we talked about general healthy living and so on and so forth, we see this all the time, that someone who has lived a very healthy life can still get cancer, or for that matter, any of the other diseases, can get a heart attack, anything like that. With all of these things, we talk about risk factors. So if you've been a smoker and lived an unhealthy life, your risks are higher, but you may still get through life and die a natural death. And someone else who has lived a very healthy life might get a cancer and die early, so to speak. So there is no absolute protections, but by and large, urban life, modern westernized life, carries with it a lot of those risk factors. I think over there, in that setting, we tend to have more exposure to pollutants and other carcinogenic elements. Our lifestyle is often such that it's more unhealthy and things like that. So, if you are living a more traditional lifestyle and have a healthier lifestyle in that context, it's going to overall lower your risk, no doubting. Um, it's a complex thing because there is, in addition to that, some areas, some aspects of genetic predisposition. So some populations tend to be more likely to suffer certain cancers. There may be certain circumstances where living in certain areas or living a certain sort of lifestyle additionally exposes you to other carcinogens. So not all carcinogens are things that come from urbanized or Western lifestyle. To give you an example from my own area, there are parts of, say, Taiwan or parts of Eastern Europe, where there are things in the natural environment and in their diet and their traditional way of lifestyle, which exposes them to a particular carcinogen that gives them a particular variety of relatively rare kidney cancer that happens much more rarely elsewhere in the world and typically in conjunction with smoking risk. So, the honest answer to your question is it can affect anyone. There are particular risks and so on that go with certain ways of life that mean that a modern Western urbanized lifestyle leads to kind of a higher rate or more common occurrence of cancer. The final thing to say is this, that cancer is one of those things, with rare exceptions, generally increases with increasing age. And there's a very logical reason why that happens. It's related to accumulating more and more trauma and changes to your genetic material. So cells forever are getting altered from their normal to abnormal. And if they get abnormal enough, they form a cancer. And if you've lived 70 or 80 years, your cells have had that much longer time to be exposed to those things and potentially form a cancer. So in urbanized, westernized environments, people generally have longer life expectancy and live to a point where that becomes an issue. Whereas often in the less developed areas, rural areas, sometimes impoverished areas, sometimes nutrition and infectious diseases and other factors may mean that life expectancy is very limited. And, globally and societally, that used to be the case. If you go back 200-300 years ago, people used to die of pneumonia and TB, and life expectancy was 50. Then, those things got sorted out and treated in the early part of last century. And then people used to live into their 60s and 70s and would often die from heart attacks and heart disease. We've got better at treating those heart problems, etc. So now people get a stent or a bypass and are living into their 80s and 90s. So now cancer is becoming much more common because all those other things are much more managed and people are living longer. So there's a variety of factors, and like many of these things, the answer is multifactorial. And as I said, the short answer to your question remains yes and no.
Okay. Now, who is dealing with cancer and the people around that patient? Everyone is going through a lot of emotional turmoil because the word cancer is not very well accepted yet
Yeah.
in the society. So, any advice from a doctor's point of view to them?
Yeah. So when you talk about the people around, you're talking about the family members, or you're talking about the treating team, etc. The
No,
treatment.
family members mainly.
Yeah, yeah. So the first thing to say is, not without reason, cancer is a very emotive word. And we deal with this all the time. So we deal with, say, prostate cancer and bladder cancer are two common cancers that we treat. And they are, thankfully, by and large, very different from most other cancers in the sense of being, relatively speaking, slower moving and less threatening cancers. Many men with prostate cancer will die of other causes, not their prostate cancer, and many will not necessarily need treatment for their prostate cancer. Some will. And that's different from some cancers, such as lung cancer, where people know that it's a very lethal cancer in many instances. Even with treatment, many people might fairly rapidly end up dying from their cancer. So, and I think many people will have a vision of cancer that looks like that lung cancer. Many people will have a vision of cancer treatment as chemotherapy that makes your hair fall out and, has a really negative impact on you. And not to minimize, I think, obviously a lot of people go through a lot of those things, but the most important thing is to find out the specific information that relates to your particular circumstance. What is my cancer? what does it mean? And that's where we have a big duty, which sometimes doesn't get fulfilled as well as it should. We need to give that information. And I say to my patients when I'm talking about this that, yes, you're hearing the word cancer, but let me put it in context. This is something that will not cause an immediate problem to you. It could cause a problem in 5 years, which is why we will do X, or this is unlikely to cause you problems over the next 10 or 20 years, which is why we will do no treatment, but we will monitor you. So we need to give that context, and then we need to give the information around what is the best treatment as we know it, and what how is it going to affect you. And I think the reason why people react negatively is because many cancers, unfortunately, don't follow that. They follow a much more difficult pathway for the patient themselves and obviously secondarily the people around them. The disease affects them. The treatments that we do to try and kind of do them good and either help them live longer or cure the cancer, whatever it might be, the treatments themselves often have very significant side effects, particularly when we're talking about chemotherapy or major surgery. So we can't minimize any of those things, but it's about sort of having the right information, the right supports, and hopefully the right treatment for each patient to ultimately, if we can cure it, we cure it. If we can't, at least minimize its impact and improve, length of life and quality of life.
Right. Okay. Now, clinical trial and cancer, those things like many times come together. Okay. And I was reading somewhere in India, apparently clinical trial sector is becoming really big
Mm,
for
mm.
all other diseases. So can you please
Yes.
shed some light on that?
Yes. So, look, I mean, I would take it away from the cancer. Obviously, clinical trials play a big role in cancer treatment, but clinical trials are important in all of medical treatment. The way clinical trials interdigitate with medicine is that that's really the only way we find out whether new treatments or new ways of managing people is any better than what we have. You or I might come up with something and say, well, this is what I was referring before, that people can advertise on the internet that take this and it's better. Is it really? I mean, what it needs is a clinical trial to show that it is better. And whether we're talking about changing diet, or we're talking about the latest drug, or we're talking about the latest surgery, we need the clinical trial to provide the evidence. And the clinical trial is where we take a group of patients and take some new way of managing them and then assess its effect and actually properly measure it and say, is this better? Is this an improvement? Is this doing what it's needing to do? And the reason that's very important to do, because most treatments will have some side effects, will certainly have some cost. And if we don't know that we're gaining something in order to compensate for added cost, for added side effects, then it's not worth doing that. And it's very easy to say, I've developed this drug and you should all take it because it's better for you. Until I can develop the evidence or show the evidence, that should not be believed. That's just advertising. So that's where clinical trials are important, and they get the greatest prominence in cancer again because of the reasons we talked about relating to what cancer means for people, and also because cancer is where new drugs and new treatments are forever being developed and needing to be tested. But it applies equally well to give a common example, diabetes. That new drugs are coming all the time, and to see whether a new, more expensive drug is actually better or not is very important before we start applying it to everyone. So I think clinical trial, and I'm quite biased. I'm involved, conflict of interest. I'm involved with our national clinical trials group for urologic cancers, and I think it's the only way we can develop new treatments and work out their impact on people and whether it actually does some good or not. And there are very many examples of things that were thought to be good. And again, going back to our previous discussion around diet and nutritional supplements and things like that are also fitted into that. A couple of the things that were thought to be potentially good for prostate cancer, when the trial was done, was found to firstly not help prostate cancer, but actually to overall have some more harmful effects, which means that no, taking those supplements is not good for you. So until you do the trial, you would sort of think, oh yeah, it's got to be a good thing for me to take that. But once
Mhm.
a trial is done, then it shows the evidence that no, don't take that extra supplement.
Okay. So as a layman, like we have a perception that the internal cancers, let's say brain or like blood or these type of things versus external cancers, let's say in your mouth or maybe prostate that way. So overall, definitely every day treatments are like progressing and everything is happening, but still there is a lot of stigma around cancer. So where we are at this point and in future there is much more hope, definitely where we are heading, if you can tell something about that.
Yeah, look, I'll clarify what you said there in that, I mean, prostate cancer is still what I would classify as an internal cancer.
Right, okay, yep.
And I guess internal versus external is a fairly arbitrary definition. Is the mouth internal or external? People talk about skin cancer, especially in the Australian context. Skin cancer is a very common thing, and even amongst the skin cancers, particularly melanoma, can be a very nasty cancer, and it's still causing potentially deaths. Again, the new immunotherapies have changed the way melanoma is treated and is giving hope to a lot of people who had very nasty cancer before. But the reason for making this point is this, that I think the key distinction in cancer is often to do with not so much where it is, but what it is. Now, there are certain cancers that are notoriously and across a broad group very nasty, and examples are lung cancer, broadly speaking, is a relatively more dangerous cancer and has negative outcomes. Brain cancer is another one like that. And there are others which are broadly speaking not so threatening. And an example is prostate that I said before. Many prostate cancers are relatively speaking not so harmful, but prostate cancer remains the number one cause cancer death in men. So even for a cancer that is non-threatening, because it's a common condition, it can still cause a lot of problems and heartache and death. So, and again, I'll go back to that previous point I made, which is that what matters most, and sorry, one more point to make is that even within a particular variety of cancer, lung cancer comes in that many different types. Prostate cancer comes in varying degrees of severity and types. So it's that specific information that is very important. So we might diagnose a prostate cancer and to say to one man, yours is one that's very indolent and we can watch this, and to another one we'll say, look, this is a threat to you, this is already spread and this will ultimately kill you in the next 5 years, is a very different conversation, but both are prostate cancers. And so that's what is very important, is the specifics of, and increasingly it is not so much about the cancer itself, but then that subtype. And there is more and more information that we can get of, how extensive is the cancer, how nasty is the cancer, what type of cancer. That will tell us more precisely as to how that's going to behave.
Right. So we are almost end of our conversation. The last question to you is, because I am trying to work a little bit in mental health area, and in that lived experience, people uh, more and more coming in front to contribute in that field. So how can the average person can contribute in cancer prevention or awareness in their community or in a state or whatever?
Yeah, yeah. Look, that's a very important point, and we from our side as well are very aware and focused on I guess patient is old word, but kind of consumer or community awareness and involvement. So to give a couple of examples, within the clinical trial space that I work in, we have a consumer advisory panel. In any trial that we're developing or running, there's usually consumers involved who tell us that, is this acceptable? We might think we're going to do this drug treatment or use that drug. We need to hear from people with lived experience as to whether that is acceptable or desirable. When we're doing measurements, when we're doing interpretations, we need their help in interpreting it in such a way that isn't just our viewpoint imposed on those who are really in the center of it, but their viewpoint incorporated into it as well. My next meeting, which I will go to after this, is with an expert who works in what we call patient-reported outcome measures, which is really, rather than measuring kind of the bulk of cancer or the survival from cancer, it's about the effect on people from the cancer. Are they feeling tired? Are they feeling depressed? So looking at the actual lived experience and trying to measure it, and we're increasingly trying to incorporate that as one aspect. So two drugs may have a similar effect on how long you live from the cancer, but if one has better outcomes in terms of quality of life and the patient-reported outcomes, it would make logical sense that that's the drug we should be using. So it's not just survival that we look at, but these other measures as well. So that's, I guess, a broad context of where I think, this is increasingly something we're very aware of. Now, what an individual or a group or a community can do about all of these things, I think, this sort of an effort where you're talking about it and hopefully this leads to people hearing about it and thinking about it is an important starting point. I've certainly been part of various other groups where either people who have family members or perhaps just general awareness, but most importantly, sometimes we have prostate cancer support groups and bladder cancer support groups, and similar exist for, I think, most of the areas. Just providing people a context where you can talk about these things and firstly have support for those who have suffered. Secondly, have some awareness within the community. Taking action. Look, we talked a bit about, don't ignore symptoms, always get them checked out. I think you've got to strike the balance right. We have some people who get so focused on any symptom they get, they're worried that it's cancer, or they really fall apart at that thought. That's not healthy. That's not good. But conversely, there are people, we see it all the time, that ignore something, and when you find out when did this start, 6 months ago, it's like, I wish you had come a bit earlier. So it's that striking that balance right. If something's there and persistent, if something seems very out of ordinary. You're losing blood somewhere, or you're losing weight, you're feeling more tired and can't do your normal activities. Get those things checked out. There are a handful of things where there are systematic kind of early testing, early detection methods, and we know about the breast screening, and now there's the bowel cancer screening and so on. So where there are screening programs available, where there is testing available through your GP, get those things done. I think those are the various things that can be done for awareness and action. And we all have a role in it individually and collectively.
Excellent. So on that, we should end our podcast here. Thank you, Shomikda, Dr. Shomik Sengupta, for your time and
Not
your
at all. It's been a pleasure.
nice
It's been a
insight.
interesting and stimulating discussion. It's
Now
it's
it's very
things that
intense for me.
that affects every one of us. Yeah.
Yeah. So on that, we should end here. This is URL podcast. As you know, if you want to recharge your energy, live life in your own terms, this is the right place. Please share, subscribe this channel, and we will come back again. Thank you very much. Thank you.